Good afternoon, everybody. Today I will be speaking on a very important and a very common topic, a disease called pneumonia. This is a case study of a patient who has typical lobar pneumonia or community acquired pneumonia. A 70-year-old male patient, emphasizing that the disease is more common in elderly, presented with abrupt onset of high-grade fever, cough, and sputum which is rust-like, that is rusty sputum. He also has chest pain which increased with deep inspiration, indicating pleuritic involvement. He was febrile, toxic, tachypnic, and chest examination showed decreased chest wall movements on the right side, impaired percussion note, increased tactile fremitus, tubular bronchial breathing on auscultation, and positive whispering pectoraloquy with increased vocal resonance on the right side. This is a classical presentation of a patient who has community acquired pneumonia and lobar consolidation. The learning objectives are to know the classification and types of pneumonia, to learn the definition of pneumonia, what is community acquired pneumonia, what is hospital acquired pneumonia, ventilator associated pneumonia, and healthcare associated pneumonia, and to understand the pathogenesis of community acquired pneumonia and pneumonia as such, and to understand the host defenses which protect against pneumonia and the risk factors which predispose to pneumonia, and to enumerate the likely organism causing different types of pneumonia, and to know the clinical features, complications, management, and prevention of pneumonia. So let us start with the definition of pneumonia or community acquired pneumonia. It's an acute infection of the pulmonary parenchyma causing inflammation, which is associated with at least some symptoms of acute infection like fever, accompanied by presence of an acute infiltrate on the chest X-ray and an auscultatory findings which are consistent with pneumonia, which I described in my case study, in a patient who is not hospitalized or residing in a long-term facility for more than 14 days before the onset of symptoms. That's the definition of community acquired pneumonia. And the clinical criteria for diagnosis of pneumonia is nuance or a progressive infiltrate on chest X-ray, plus at least any one of the two following conditions. That is, there is X-ray shows a progressive infiltrate, and in addition, any two of the following, if they are present, we can make a clinical diagnosis of pneumonia, like fever, cough, which is productive of purulent or rusty sputum, and the CBC shows leukocytosis. Any two of these three conditions in presence of a new or a progressive infiltrator on chest X-ray, we can make a diagnosis of pneumonia. Pneumonia can be classified as community acquired pneumonia, which I have just mentioned, in which patient has acquired pneumonia outside the hospital or in extended care facility. Then hospital acquired pneumonia, where patient has developed pneumonia after 48 hours from admission. Ventilator associated pneumonia, that is, patient has developed pneumonia after 48 hours of endotracheal intubation when it's put on a ventilator. Healthcare associated pneumonia is that which is when it develops in patients who are in long-term care facility in nursing homes. Patients on hemodialysis come to the hospital for their hemodialysis, or outpatients who are taking up treatment for outpatients department, and for wound care. These are healthcare associated pneumonias. Pneumonia is basically an 8th leading cause of death in US, and highest incidence occurs in children less than 5 years of age, and in elderly more than 65 years of age. Mortality specifically is disproportionately high in elderly, and despite a lot of antibiotics, we see that the case fatality rate for pneumonia has not changed much. If you see the pathogenesis, the microorganisms can reach the lungs by any of the three mechanisms, that is by inhalation or aspiration of upper respiratory flora and or by through bloodstream through the hematogenous route. And it results when the host defense mechanisms which actually prevent pneumonia, which fail to protect against a microbial challenges. So what are the host defenses which prevent pneumonia? We always are surrounded by so many microorganisms, viruses and bacteria, but we do not develop pneumonia because there are certain defense mechanisms in the body which prevent pneumonia. The cough reflex, the gag reflex, and the pseudostratified ciliated epithelium of the respiratory tract is lined by a mucociliary excavator, which always the cilia are beating in the upward direction, preventing the organisms to go down into the lower respiratory tract. The respiratory epithelium also secretes IgA antibodies, and there are alveolar macrophages. In addition to these, in the blood and we have humoral immunity, antibodies are present and cellular immunity is present, which prevent pneumonia. So these are host defense mechanisms, and any break in these defense mechanisms predisposes a patient to develop lower respiratory infections and pneumonia. Now, what are the risk factors for community acquired pneumonia? As I've said, elderly people are particularly more common to develop pneumonia, which led William Osler to, way back in 1898, to say that pneumonia is a common friend of the elderly because it revisits him repeatedly. As we grow older, the immunity drops and the chances of developing lower respiratory infection and community acquired pneumonia is high. Smoking causes damage to the mucociliary excavator, allowing the organisms to go down into the lower respiratory tract. Immunosuppressed patients, that patients who are suffering from HIV infection or AIDS, patients who have diabetes, or patients who are on steroids or other immunomodulatory agents, immunosuppressive agents, who are on taking anti-malignant chemotherapy, organ transplantations, patients who have malignancy, and patients who have leukemias and lymphomas, there is immune suppression, and these people are more likely to develop community acquired pneumonia. Patients who have some structural damage to the lungs, as occurs in COPD, and patients who have chronic asthma or acute patients who have repeated attacks of acute severe asthma are more predisposed to develop pneumonia, or patients who have a pre-existing lung disease like mucoviscidosis, they have more chances of developing pneumonia. Patients who drink alcohol, who have a seizure disorder, or who have a stroke, and who have gastroesophageal reflux disease are more prone for aspiration and that might lead to pneumonia. Now let us have a look at what are the common bacteria which can cause pneumonia, the microbiological profile of bacteria. There are typical organisms and atypical organisms. Typical presentation is when a patient presents with abrupt onset of high-grade fever associated with cough, sputum production which is rusty or purulent in color, and may have systemic manifestations. And these patients, a very atypical presentation, the onset is very insidious, and patients may have only low-grade fever and mild cough and non-productive cough. The common organisms in community-acquired pneumonia, that means the patients who have not been hospitalized, who develop pneumonia in the community and have a typical presentation, the most common organisms are Streptococcus pneumoniae and Haemophilus influenzae. Rarely, in community-acquired pneumonia can also be caused in typical and present in a typical manner of abrupt onset of high-grade fever, are Staphylococcus aureus and Klebsiella pneumonia, These organisms are particularly important because these organisms like Staphylococcus aureus and Klebsiella pneumonia are known to cause suppurative and necrotizing pneumonias and can lead to a lung abscess if not treated adequately by inadequate doses by antibiotics given for adequate time. Patients who present with atypical presentation, who have low-grade fever and cough, the most common organisms are Mycoplasma pneumoniae and chlamydia group of organisms like Chlamydia pneumonia and Chlamydia psittaci. Legionella species also are known to cause atypical presentation. Recently, this differentiation of pneumonia into typical and atypical has been discontinued. Why? Because it is many times this is not true. It is also important to understand that 40 to 60% of patients we are not able to identify the organism, and in about 5% of patients more than 2 organisms may be responsible for pneumonia. Atypical organisms are distinguished from typical, that means chlamydia group of organisms and mycoplasma are distinguished from other organisms which cause typical presentation like Haemophilus influenza and Streptococcus pneumonia. That atypical presentations are not organisms are not detected by gram stain on the sputum, and they are not cultivatable on standard media, and they respond to a macrolide antibiotic like azithromycin. Other bacteria which can cause pneumonia include anaerobes. Now these are common organisms which cause aspiration pneumonia, and the organisms, anaerobic non-spore bearing organisms are normal commensals of the upper respiratory tract, and this include Peptococcus, Streptococcus, spirochetes, and these these are basically commensal organisms and can cause pneumonia when the immunity of the patient drops, and when aspiration can occur, which patients who are alcoholics, who have developed a seizure disorder, or patients who have a posterior circulation stroke in which 9th and 10th nerve is damaged and the cough reflex is suppressed, and patients who have gingivitis. In this situation, patient is particularly prone to develop aspiration pneumonias, and these anaerobic organisms can infect the cause pneumonia, and they give rise to halitosis, which means that there is a putrid sputum and foul smelling sputum is present. Other organisms which can cause pneumonia are viral and fungal pneumonias. Viral pneumonias have particularly gained a lot of importance recently since the COVID pandemic, where we had COVID, an RNA virus causing devastation and causing pneumonia. And then there are fungal pneumonias also. Now let us look at what are organisms which can cause viruses which can cause pneumonia. These include influenza A H1N1, that is influenza viruses, swine flu, that was a new virus. In fact, this century we witnessed 2 pandemics. First pandemic was witnessed in 2008, which was caused by swine flu, which is also called influenza A H1N1, and this was first identified in Mexico because of genetic reassortment of 4 types of viruses, and that a new virus was formed. Then we had another pandemic of coronavirus, that is COVID virus. We had SARS-2 virus, which was responsible for the COVID pandemic. SARS-1 actually caused a pandemic sometimes in the earlier part of this century, which was not as devastating as the COVID virus pandemic. The other viruses which can cause pneumonia are adenoviruses and the respiratory syncytial virus, that is RSV viruses. Bird flu is avian influenza, which is very dangerous in birds, but can sometimes jump species and may cause infection in humans, rarely. And it is caused by H5N1. measles, herpes simplex virus, cytomegalovirus, human herpes virus 6 are other viruses which can cause pneumonia. Now, viral pneumonia, actually viruses cause partial paralysis of the mucociliary escalator, which lines the pseudostratified epithelium of the respiratory tract, and that leads to increased risk of secondary bacterial infection. After a viral pneumonia, secondary bacterial infections can occur, especially Staphylococcus aureus pneumonia is a known complication following influenza infection. Pneumonia in the immunosuppressed is a total different entity, and where bacterial pneumonias actually are common, but Pneumocystis carinii pneumonia, which is caused by Pneumocystis jirovecii, which is a yeast-like fungus, is also a very typical infection which occurs in patients who have AIDS when the CD4 count drops below 200 microgram per millimeters, and then we have other infections like fungal pneumonias which are caused by histoplasma, cytomegalovirus pneumonias, and Mycobacterium avium complex, which is atypical mycobacterium, are responsible for causing pneumonia in patients who have AIDS, in which the CD4 count has dropped below 50. So, Pneumocystis carinii, particularly common in AIDS when the CD4 count is less than 200, but when it drops to further down to 50, then MAC, that is Mycobacterium avium complex, which is atypical mycobacterium, can also cause pneumonias. Let us have a brief introduction to Pneumocystis carinii pneumonia, which is a yeast-like fungus which is caused by Pneumocystis jirovecii. CD4 counts are usually less than 200 cells per cubic liter and microliter, and they are rare in immunocompetent patients, which means in an immunocompetent patients, Pneumocystis carinii pneumonia is very uncommon. And it is a typical infection, AIDS defining infection, which is seen in immunosuppressed patient. And patients present with a triad of fever, non-productive cough, and exertional breathlessness, and may sometimes develop exertional cyanosis. Pneumothorax can occur, and patients may have on the chest X-ray widespread pulmonary infiltrates and the PaO2 drops, which leads to cyanosis. Treatment is by giving Septran, which is co-trimoxazole or trimethoprim sulfamethoxazole combination in high doses. Septran DS is given 2 tablets 8 hourly in patients of treatment for Pneumocystis carinii pneumonia. Now, certain pneumonias can occur because they are exposed to zoonotic or to animals, and people who are exposed to bad droppings can develop histoplasma capsulatum, which is a fungal pneumonia can occur. People who are exposed to birds can develop chlamydia psittaci infection, which is known as psittacosis, bird droppings. And from birds, we can also develop avian influenza, that means who are exposed to poultry. People who are exposed to rabbits can develop a disease for infection by Francisella tularensis, and people who are exposed to farm animals like sheep, cattle, or parturient cats, more commonly they can get infection or pneumonia due to Coxella burnetii or Q fever. There are 4 pathological stages of pneumonia, and this will be taught to you in pathology as well. First is the stage of congestion, where there is edema in the alveoli and there is congestion of the lungs and particular part of the lung. This leads to extravasation of RBCs, and that leads to red hepatization, that lungs become solidified. Resolution starts with gray hepatization, and then there is a stage of resolution. So, stage of congestion, red hepatization, gray hepatization, and resolution are the stages, pathological stages. See, as you can see here in pneumonia, there is fluid on the air spaces, and a particular part of the lung becomes consolidated. As I've said, typical presentation, most common organism is Streptococcus pneumonia. The other common organism is Haemophilus influenza. They are the most common. Streptococcus pneumonia, in fact, is the first common cause, 2/3 of cases of community acquired pneumonia. These are the Streptococcus are basically gram-positive diplococci, and typical presentation of abrupt onset of high-grade fever associated with chills, malaise, rusty or purulent sputum, and a pleuritic chest pain and cough are characteristic features. On an X-ray, we see one part of the lobe is totally consolidated, whitish, opaque, and that is a typical picture of lobar consolidation seen with Streptococcus pneumonia. 25% of these patients may develop bacteremia and may develop serious side effects. Now, if you get a patient who has pneumonia and lower respiratory infection and is bringing out sputum, certain characteristics have to be inquired. If it is rust-like, it is called rusty sputum, which is seen with Streptococcus pneumonia. Green sputums, with greenish tinge to the sputum, is seen with Pseudomonas and Haemophilus influenza. Pseudomonas gram-negative organisms. Klebsiella pneumoniae typically causes red currant jelly-like sputum. And anaerobic infections, as I've told, which are normal commensals of the upper respiratory tract, which can cause infection when the mucociliary excretory is damaged. And anaerobic organism infection will lead to foul-smelling sputum, which is called halitosis. Atypical pneumonia is caused by Mycoplasma, Chlamydia, and Legionella, where the onset is insidious onset, subacute, where milder symptoms are present. Patients have non-productive sputum and cough, and there is no sputum. And if you take an X-ray, it shows subsegmental infiltrates or patchy infiltrates on the chest X-ray. Mycoplasma pneumonia typically occurs in younger patients, in students who are living in hostels, and it might cause a local outbreak there. Extrapulmonary symptoms like anemia, rashes, headache, sore throat is common. Myringitis, that is inflammation of the eardrum, can occur with mycoplasma. They develop cold and agglutinin antibodies, and that can lead to some problem with hemolysis. And chlamydia group of organisms, Chickadee, and are another group of organisms which cause atypical pneumonias. Legionella typically causes high mortality rate and some waterborne outbreaks, which typically occurred and first described in people who stayed in a hotel where the AC was contaminated. Now just a brief description of what viral pneumonias and influenza A H1N1 is, or swine flu. Typically, viral pneumonias in patients present typically with high-grade fever, cough, breathlessness. But in addition to respiratory symptomatology, the patients have extrapulmonary symptoms which are very common. Patients develop body ache, headache, myalgia, muscle pain, arthralgia, and they also sometimes can develop nausea, vomiting, and loose motions. And they typically in the lungs, they can cause bronchopneumonia, where there is patchy infiltrations on the chest, X-ray. And this may sometimes progress to a more serious condition called acute respiratory distress syndrome, where patients need to be put on ventilator. And they may have some extrapulmonary manifestations like meningitis. Many of them can develop myocarditis, and that may sometimes cause death as well. Now, there is a condition called suppurative pneumonias or necrotizing pneumonias, where the typical organisms are Staphylococcus aureus and Klebsiella pneumonia. Staphylococcus aureus, I have just mentioned that it was a common complication after influenza infection, pneumonias, and spread usually occurs through hematogenous spread. In Staphylococcus aureus, it causes lower lobe involvement. It causes necrotizing vasculitis and may lead to some damage of the lungs, and can lead to formation of what are known as pneumatoceles, which can rupture and cause pneumothorax as well. And basically, patients who have suppurative or necrotizing pneumonias caused by Staphylococcus, which involves the lower lobes, can lead to lung abscess formation or subsequently to bronchiectasis, and cavitations and empyema, which is pus in the pleural space, are complications of this condition. And the hypoxia, hypoventilation and hypotension can also occur because spread can occur through the lungs and cause septicemia, and that can lead to septicemic shock. And they have treated with higher antibiotics like vancomycin, linezolid, especially in patients who have methicillin resistant Staphylococcus aureus infection. They are treated with vancomycin, and vancomycin resistant Staphylococcus aureus infection, VRSA, the drug of choice is linezolid. So MRSA, the drug of choice is vancomycin. VRSA, the drug of choice is linezolid. Klebsiella pneumonia, another organism which can cause necrotizing pneumonias, which can lead to lung abscess. It involves the upper lobe, and it can sometimes, because it is causing infiltration of the lungs, it can sometimes be confused with tuberculosis. But tuberculosis, the presentation is low-grade fever, evening rise of temperature, and these anorexia, loss of weight, and chronic cough. Whereas in Klebsiella pneumonia, when the upper lobe is involved, the patients present with abrupt onset of very high grade fever, and this is how we can differentiate, but many times it can be confusing as well. The typical chest X-ray shows a consolidation or the opacity of the upper lobe, and the classical sign described with Klebsiella pneumonia is a bulging fissure sign on chest X-ray. That means the minor fissure bulges downwards, that is called the bulging fissure sign. Pneumonia in the elderly is a challenge because patients who are elderly may not present with fever and typical symptoms of cough and expectoration, by which we make a diagnosis of pneumonia or lower respiratory infection. With elderly patients, the presentation is very atypical. They present with new onset of worsening confusion, and which might be, and they may not have any fever. Once I was called to see my friend's father, and the only complaint was that the patient was drowsy, and when I examined the patient, he had no fever, and the patient, when we did the X-ray, which showed pneumonia. So basically, I suspected stroke in this patient, but now when a chest X-ray was done, it showed pneumonia. Patient responded to the treatment with antibiotics. So what I am trying to emphasize is the elderly people may not present with typical presentation of fever, cough, and other things, and they may only present with altered consciousness, a delirious or a confused state, and without any fever. Now, typical signs in a patient with lobar pneumonia are that on general examination, patients are usually high-grade fever. They look ill, they look toxic, they have tachycardia, tachypnea, and sometimes there is secondary infection of the herpes labialis in the lung, in the lips. You can have herpes infection, simplex infection, and on examination and in severe, they are usually tachypnic and without being dyspneic. A typical sign of pneumonia is that the respiratory rate increases, but there is no use of accessory muscles of respiration. They may also become cyanosed if the PaO2 drops, because it causes hypoxia is common complication of pneumonia. And if they develop hypoxia, they can develop bluish discoloration of the tongue, which is called cyanosis. On examination of the chest, they have very typical findings by which you can make a diagnosis. The patients will have decreased chest wall movements on the side where the consolidation or pneumonia has occurred. Patients will have decreased chest wall movements, and if you put your hands on that and ask the patient to say 1, 2, 3, that is vocal tactile fremitus, that is increased. Now remember that tactile vocal fremitus is increased only in pneumonia. In all other lung pathologies like fibrosis, collapse, or in patients who have pleural effusions, all that thing, it is usually decreased, but in consolidation and pneumonia they are increased. And percussion note is dull or impaired, and on auscultation we find that the air entry is decreased in the area of consolidation, and the patients have tubular bronchial breathing, which is high-pitched bronchial breathing. And they have increased vocal resonance, which means that if you put your stethoscope on the chest and ask the patient to say 1, 2, 3, it is heard very nicely in the ears. that is increased vocal resonance is seen. Whispering pectoraluki is the first thing to come and the last to go in lobar pneumonia, in which we just ask the patient, we put our stethoscope in the area where the consolidation is there and ask the patient to whisper 1, 2, 3, 1, 2, 3, 1. And it is, you feel as though the patient is whispering right into your ears. That is called whispering pectoraluki, which is a sign of consolidation which comes first even before bronchial breathing occurs and which goes last. That means even in the bronchial breathing has disappeared, the patient will have whispering pectoraluki. In the phase of resolution, patients will develop coarse crepitations. That means when the patient is improving. So with these typical findings, you can make a diagnosis of lobar pneumonia. Then this is what is a diagrammatic representation of the symptoms and signs of pneumonia, in which patients have high-grade fever with chills, may have bluish discoloration of the tongue, and that may have, and the patients have cough with expectoration, may have shortness of breath, pruritic chest pain, sometimes hemoptysis, and they have muscle pain, fatigue. They maybe have headaches and loss of appetite, mood changes, then the blood pressure may drop. They may develop myocarditis, and they may develop septicemia. Arthralgia and nausea, vomiting are other symptoms. If you look at this slide, this is a slide which was very commonly used during COVID period in viral pneumonias, and we classified patients into mild, moderate and severe disease. In mild disease, we had patients who have upper respiratory symptoms of cough, sore throat, without any shortness of breath and without any hypoxia. That means hypoxia is tested by doing SpO2. Now everybody is aware of what the pulse oximeter is, which is now the fifth sign of vital sign. And now any patient who comes with breathlessness, we always check for SpO2 with the help of pulse oximeter. Even the lay persons now are aware of how to use a pulse oximeter, especially after the COVID pandemic. And normally it should be more than 94%. If it is less than or equal to 93%, and patient has any respiratory rate which is normally between 12 to 18, if it increases more than 24, then it is classified as moderate disease. But in mild disease, the respiratory rate is normal. There is no tachypnea. The patient's respiratory rate is about 12 to 18, and their SpO2 is normal. But in moderate disease, the respiratory rate tachypnea is there, which respiratory rate increased to 24, and SpO2 is less than 93% or equal to 93% or between 93 to 90%. And that is moderate disease. And severe disease is when the respiratory rate increases more than 30 per minute, and the SpO2 is less than 30. SpO2 is less than 90% on room air. This is how we can classify viral pneumonias, COVID pneumonias. Now, pneumonia is more prone for developing complications, and one of the most common complications which can occur is parapneumonic pleural effusions. That means at the site which could be synpneumonic or metapneumonic. Synpneumonic means with the pneumonia, when there is a pleural involvement, patients can develop pleural effusion. And with this pleural effusion, it is usually clear, and pus cells are found in only rarely. This may complicate to develop pyothorax or empyema thoracis, that is pus in the pleural space. And patients can develop lung abscess, especially seen because of in suppurative pneumonias or necrotizing pneumonias, which are basically caused by Staphylococcus aureus in the lower lobes and Klebsiella pneumonia in the upper lobe, can lead to lung destruction and lead to lung abscess and bronchiectasis. The organisms can escape from the lungs into the blood and cause bacteremia and septicemia and multi-organ dysfunction. Patients are toxic, and patients can develop what is known as toxic hepatitis, in which patients can develop icterus, and patients may develop arthritis. Organisms can reach the brain to cause encephalitis and can cause meningoencephalitis and meningitis, and it can lead to liver abscesses and brain abscesses. Myocarditis can occur, endocarditis can occur, hematogenous involvement like disseminated intravascular coagulation can occur, and patients can develop septicemic shock as well, or multiple pyemic excesses. These are some of the common complications which can prove fatal unless they are treated appropriately with antibiotics and IV fluids, and with proper uh, oxygen therapy and antibiotics. So diagnosis is made by history and complaints of the patient of high-grade fever and high-grade fever, cough, and typical signs which are there on examination and auscultation of the chest. This can be confirmed by doing an X-ray chest, which will show consolidation, which could be involve the whole lobe in patients who have opacification of the whole lobe, which is called lobar pneumonia or lobar consolidation. And these are, there could be patchy involvement, like patients who have bronchopneumonia can have patchy involvement. And microbiological testing with sputum, like gram staining and AFB staining, culture and blood culture, other investigations which can be done to isolate the organisms. But it is important to understand that despite all these investigations, it is many times difficult to isolate any organism, and we need to start antibiotics empirically. Serology is another way in which we can diagnose, especially in atypical organisms like those caused by chlamydia and mycoplasma. Serological, by doing the ELISA testing, IgM and IgG antibodies can be done, which shows a fourfold increase. But the disadvantage is that serology becomes positive, like ELISA of IgG and IgM would become positive only after 5 to 6 days of infection, and would not be possible to make a diagnosis early on. And the confirmatory diagnosis, especially in viral pneumonias and also in rickettsial infection, can be done by doing what is known as the RT-PCR. And all of you are aware now, after the COVID pandemic, RT-PCR has become so common. That is polymerase chain reaction, real-time polymerase chain reaction. Thank you for a patient hearing, and I will be discussing the lab tests and the management of pneumonia complications and pneumonia in my next talk. It is important to understand that we can predict the organism depending on the presentation. If a patient has a typical presentation and has been not hospitalized and has acquired the infection in the community, that is community acquired pneumonia, there are two most common organisms, like is Haemophilus influenza and Streptococcus pneumoniae. If a patient has developed hospital acquired pneumonia, that means he has developed pneumonia after 48 hours after hospitalization, then the organisms are slightly different, where we have gram-negative organisms, and that is known as nosocomial pneumonia, and that the organisms like Pseudomonas are more common in causing infection there. If a patient has developed suppurative necrotizing pneumonias, the most common organisms are Staphylococcus aureus, which cause infection in the lower lobe, whereas Klebsiella pneumonia, which causes infection in the upper lobe. And if a patient has developed ventilator associated pneumonia, then that means who has developed pneumonia after 48 hours after infection. It is important to understand that the organisms there would be more dangerous, and they will develop multi-drug resistant organisms like Enterobacteriaceae and Acinetobacter baumannii, and many organisms which are resistant to multiple antibiotics. So we can predict the organism depending on the presentation and depending on the site where the patient has developed the pneumonia, and we have to start with empirical antibiotics, despite the fact that we are not able to isolate the organisms. I'll discuss the rest part in my subsequent talk. Thank you very much for a patient hearing.